Okay. Um, Hello, everyone. Welcome to our webinar on community-based screening and identification of children at high risk for cerebral palsy. This is our third webinar of the webinar series of JLM CPR this year, and we are very glad to have Dr. Kat Benfar from University of Queensland and Dr. Mahmudul Hassan Alimam from CSF Global Bangladesh as a speaker for this session. I will not delay the session with I will not more delay it more. I will just directly go to our main content. So you all probably have received PDF of this document. This is just a brief outline how we are going to structure our session today. There will be a survey where we will introduce, we will just like to know a little bit of your experience in this topic and this theme. Then we will learn a lot from Dr. Kat Benfar from on LeapCP model. I'm sure you all have heard about the LeapCP model, and if not, then Kat is here. Then we will have a brief question and answer session, and then followed by that, we will have our second speaker, Dr. Mahmudul Hassan from Bangladesh, who will be discussing about their pilot program on early detection of CP in Bangladesh. Similarly, to the previous session, like we will have Q&A. Feel free to text, leave message in the chat box or ask directly when the session is when there's a Q&A session. And at the end, we would like to have your feedback and we will close the webinar. That's the overall summary. Okay, so I'm going to go to the next slide, which you already have seen probably. So this is for us to come so that we can reach out to you for future webinars and information related to JLM CPR activities. So could you please, I will give another minute for everyone to complete their details. If not, I will also copy this code on the chat box so that you can complete later. In the meantime, if anyone has anything to say, you could.
Hi everyone.
Hi, Hilary.
How can we send the code?
Can you access the code?
I don't know how to do it, please.
Okay, so please go to menti.com and then they will ask for this password. Just copy this password 74123648. If not, then just scan this QR code on your camera, like QR scanner.
Okay, thank you.
Thank you so much, Hilary. If you find any technical glitch, please text your name, email address directly to me. I would be able to copy that to this section as well. No worries. Okay, let's move to the next slide. Here, as you probably have seen previously, we would like to know about your experience in terms of early identification of children with cerebral palsy in your setting. Similar to the previous slide, could you please, sorry about that typing error, I forgot to, yeah, anyway. So could you please scan this QR code or put this, use this code to send your response to us? Or you could text your response to chat box. I can copy that. I and my colleagues can put that in here.
personne de positive, sa réunion a commencé. Il veut des choses interactives. Il faut répondre ou
Okay, not very interactive yet. You could text your response to chat box though. Do you what are the key challenges do you think you face in your settings in terms of early identification of children with disabilities? Okay, next, okay, awesome. A few challenges already came. Moving to the next slide. So does your program involve any community-based identification program, identification activities? Like do you, the place where you work or the setup you have, does this involve any community-based activities? Okay, no, yes, awesome. 3 yes, 1 no. 2 not yet, awesome. Yeah, that's understandable. Okay, majority has existing component regarding community-based identification. That's really good to know that, okay, so both Kat and Mahmoudul, you have an audience who would be really benefited by the discussion, I assume. Let's move to the next slide. What tools do you commonly use for screening infants at high risk for CP? Again, exclude, yeah. We all are aware about general movement assessment, but I'm not sure how many of us actually have used in our setting. Yeah, awesome. GMA Hein. Any other screening tool? GMA and Hein. Daisy, okay. RNDA. So many tools. GMA and Hein. GMA. There's one more, which I cannot see in the screen. Sorry about that. I think Malawi Development Assessment Tools, something. Yeah. So this gives us some idea that we all are keen to early, like we have started some activities in terms of early identification and screening of children, which actually is going to be our discussion for the next 45 minutes. So I thank you so much. Yeah, there are so many responses, and I will share these screens later once we have our webinar completed. So moving forward, now we will, as I mentioned earlier, and you already you already know that we have our speaker, Dr. Kat Penfar, who is a postdoctoral research fellow with the Queensland Cerebral Palsy and Rehabilitation Research Center of the University of Queensland. Kat, I would like to welcome to our webinar and thank you so much for your time. I will stop sharing this screen so that Kat could start her session and discussion. Kat, over to you. Thank you.
Thank you so much, Israt. And I just want to congratulate your team as well at the outset for such a wonderful initiative. I just think it's really wonderful. The more we can share and learn from one another, the richer and stronger we get, isn't it? And the better the services are that, you know, are provided for our communities. So yeah, congratulations on this initiative. And I look forward to being part of future or learning from future workshops. Before I kick off, I just wanted to really give a very strong acknowledgement to all of our partner agencies. I'm here as one person in amongst so many wonderful organisations and services, and so I just really want to acknowledge them up front and the funding agencies that have provided to enable all of this work, and of course the families that have participated. I'll just quickly, I think Raj I saw pop on, so I'll just get him just to pop his camera on if it's working well enough, Raj, and say g'day. And then I don't know if anyone else from our team is on yet.
I see Mr.
No.
Raj coming.
Anyway, I'm sure, so my hope is just to keep this as, I always talk a little bit too much, but to keep this as tight as I can, and give enough time for you guys to really chat with hopefully Raj and Gulam from India and Anna from Georgia will be able to be online this afternoon. And so really to learn from their wisdom, because they're the ones on the ground implementing. And I'd also just like to acknowledge the ownership of our country, Australia, to our First Peoples Australians who walked the land far before European arrivals and cared for it, and really pay my respect to their ancestors and descendants. So LEAP, excuse me, as Israt mentioned, is the Learning Through Everyday Activities with Parents program. And so it's not just limited to the identification and screening components, but really also that early intervention piece. And it's built on the idea of being parent delivered. We believe parents are their baby's first and best teachers, and want what's best for their babies. And it's community based. So we really want it to be in the community, in the home, to prevent some of those geographical barriers, but also really to embed into the baby's natural learning spaces. And of course, we know that detection and intervention in the first year of life is critical for that neuroplasticity and learning. For anyone who's interested, we do have our protocols published, 3 of them at least, and so you can look them up if you want more detail on the program. But at the moment, LEAP started off in West Bengal in India, and that was an RCT that we conducted to test its effectiveness. And we have just recently published the results. I should have put the publication up, but it's been published in Pediatrics if you look at one of the recent issues, and I can send that around later. And that one of the partner agencies, the Asha Bhavan Centre, has had ongoing implementation of the LEAP program since the conclusion of the trial. We also then, following on from there, have been testing it in our First Nations population in Australia, as well as Georgia in Eastern Europe and Sri Lanka. So you can see some very different cultural contexts. Just to give you a very quick snapshot of what to orient you to the program. So our target recipients are babies in the first year of life, so 12 to 52 weeks corrected age. And we generally screen a fairly broad set of risk factors, and I'll talk more about that shortly. Our 2 key screening tools are the general movements and the Hammersmith. And we know that there's some key early life risk factors that really mean that these babies would benefit from the screening programs that we've got to offer. This is by no means exhaustive. The Cerebral Palsy Alliance have some really beautiful resources that give quite detailed lists of risk factors. And in addition to those birth identifiable risk factors, we've also got things that families or health providers can notice in the baby in that first year of life that can also indicate that bub would benefit from some additional screening. For those who aren't so familiar with general movements, I've just put these 2 up just to give you a sense of how accessible something like the general movements assessment is once you've got that certification training, and I'll talk more to that soon. But the general movements, it's just a 3-minute video of baby lying on their back with just a nappy on, and the mum or a health worker can just capture that on their smartphone. And what they're looking for at that 3 months, so it's got a very specific age where you need to capture the video between 12 and 17 weeks corrected for prematurity. But we're looking for these little fidgety movements, which are kind of little twitches in the joint the wrists, shoulders, hips, ankles, where you can see the fidgety movement. So this is just 2 videos. I won't show them for long, but just to give you some sense of of those 2 different bubs. So bub on the left is a baby that we would expect to go on to have typical trajectories of development, as well as the fidgety movements. You can see they've also got a very lovely repertoire of movement, whereas bub on the right is what we would call absent fidgety, and so they don't have those little twitchy movements in the joints. And you can see in addition to that, they've also got other patterns of movement that are fairly poor anti-gravity movement and poor repertoires. So there's other things that clinicians have typically looked for, but for the general movements, it's those little fidgety movements. And again, just so that people have some concept of what these tools are when we're speaking to them through the presentations, the other is the Hammersmith Infant Neurological Examination. And I do understand that in a future webinar, you are going to get lots more information about some of these tools, but the HIND can be used between 3 and 18 or even up to 24 months. And it's a scoreable, so standardized neurological exam. And you can score bub out of a total of 78. And there's some very clear published cut points that are predictive of cerebral palsy, as well as other adverse neurodevelopment. And again, not the focus of today's webinar, but to give you the full picture. Once we identify a baby that needs that additional support, then we fast track them into the LEAP intervention. And that consists of 3 key components. We've got goal-directed active learning, which is a goal that's been identified by the parents or the family and can be anything from gross motor to upper limb, communication, vision, feeding, nutrition. So it can be really any area of development. There's also parent education around how babies learn, responsive caregiving, parent mental health, feeding and nutrition, and then the CP learning games, which really promotes using home-based materials and how to modify them for a baby that might have limitations to their physical movement so that they're still getting the cognitive learning. And one of the key differences of the LEAP program is that delivery through a peer trainer or the local community, and they're supported, the community disability workers are supported by an allied health coordinator. So to zero back to where we started around the identification and screening. So there's so many decisions, and I think that's one of the things that I really wanted to highlight within LEAP, is that we don't have a single model, particularly around our identification and screening. But there's a series of decisions that we work through. A series of decisions that we work through to try and unpack what's going to be the best fit for the local community. A few, I won't go through it in huge detail, but starting at the beginning at the target population. So whether you're looking at a specific geographical area that your organisation services, if there's a specific profile of risk, so if you want it to be a general disability program or one targeted more towards cerebral palsy or neurodevelopment, that's going to be different with how you identify them, how you screen them, and which babies you're selecting, and of course the age and the purpose of the screening. So in LEAP, we're really looking at identifying babies that we think are going to go on to benefit from the LEAP home-based intervention, as opposed to something where you might be screening for the cerebral palsy registers, where you're wanting much more of a systematic kind of picture of all of the babies in an area or a cohort. With regards to the identification, you'll hear some other models today, but anything within LEAP, we use anything from household surveys to a key or a modified key informant, referral based from existing health services, and partnerships within medical services. And I just wanted to highlight with each of these steps the real important part that training has to play. So it's not just getting people to identify these babies, but all of the training and support that's required to really upskill them in that. Similarly with the general movements video collection. So I often think of the actual collection of the general movements video separate from the scoring, because you don't necessarily need the same people collecting them from scoring them, but thinking through carefully who's going to do each of those parts. what and when and how many, so which combination of tools and how at what time points. The location, so if it can be embedded within the home, I think that really promotes access for a lot of families in our communities. What kind of training and ongoing support is needed for each of those roles, and what resourcing is required. And I also just really wanted to not have that final piece that sometimes can drop away, which is the communication back to the family about the results of that screening. So whether that's communicating a specific diagnosis in conjunction with their primary care team, or whether that's just talking about the fact that these tools indicate Bub might need some extra help to learn to move and grow. So there are different ways we can communicate it depending on the expertise of the team, but we need to really think carefully about how we're communicating with the families. And of course, all of these decisions that we've got can be influenced so heavily by your own unique culture and socio-political context, the awareness and beliefs on disability in your countries, your differences between your organisation and workforce, geographical, so for example, going to a mountainous country like Bhutan compared to a flatter or a geographically dense country like Kolkata, and the funding that you have available, which came up in those earlier barriers. So back to what this has looked like on the ground with some of our LEAP partner sites. So to date, we've screened almost 3,000 infants on the general movements and the hinds. So the teams have a lot of experience using them. And I think we have learnt so much from the variety in the partner agencies with how to do the screening. So with our work in India, in West Bengal, India, we originally had 3 partner sites. So the first was a disability organisation working in rural communities, the Asha Bhavan Centre, the Child in Need Institute, which was a community child protection agency working in the slums or the informal settlements in Kolkata itself. And then Dr. B.C. Roy Hospital is a big tertiary hospital that is in Kolkata itself, but provides services out to the rural community to the east. And we used quite a different process for identifying babies between them. Really, the community sites were a mixture between household surveys, building on partnerships, and education and awareness groups. And I'm going to talk to these in more detail shortly, compared to the hospital site where we really embedded within their existing high-risk follow-up clinics that they were already conducting. And similarly, in the community sites, we really banked on harnessing the power of the local community. So we trained local community members to be the ones going out and identifying babies, as well as taking the general movements or administering the hind. Then in First Nations Australia, so this is a statewide multi-site project that we've got happening at the moment, but it's limited to our First Nations or First Peoples of Australia. And we've really identified these not through community methods, but through, again, the NICU graduates, as well as an early detection network that we have operating across the state. But we have trained up Aboriginal health workers as one of the key points of contact with the family to really promote that engagement and connection. And in Georgia, again, it's a much more of a hospital-based population, but I just wanted to mention it for completeness, just to give you some scope of how different sites can look. And they all go on to then have the community-based intervention program. So Georgia really is a NICU inborn or outside referrals into the hospital, but parents can self-refer to this program, and the general movements and hind are both being done by the neurologists. So that's a little bit different from some of the other sites. And then in Sri Lanka, we have 2 different project arms happening. So we had one in the tea plantations, which was specifically developed to support families who were employed in the plantations. And the team there collaborated with the child development centres to really promote and do universal screening with the general movements. And then in addition to that, they ran some health camps where they could do it more of a tiered screening model. And again, I won't unpack some of these terms. We'll talk about them as we move through the presentation. Compared to then in the regional site, they're using a lot of the existing referral pathways that are established within some of the government disability agencies. But they're still looking at a very much a home-based administration of the screening tools. So you can see that LEAP doesn't use a single approach to identifying or screening the infants. And so what I've tried to do is distill down some of the key principles of the LEAP screening model, and we'll explore some examples of these in turn. But if I was going to capture what makes the LEAP screening program, it's around access equity. So we really want the program to go to the families rather than families having the barriers to access the services. Building on local strengths and partnership with local community, utilising gold standard screening tools, and a priority given to scalable and sustainable processes. So equity for access is one of the key features of the LEAP screening program to really enable all members of the community to be able to reach that screening. And one of the key strategies we used was to upskill the local community members as disability champions, which is a little akin, not probably as systematic, and I'm sure Mahmoud will talk to this in a lot more detail, but to the key informant type method. So in LEAP India, we have a team of community disability workers who are women employed not only for the identification and screening of the babies, but these women also were the ones who journeyed with the family in the LEAP home intervention program. So many of these women are parents of a child with a disability. Some had a disability themselves, and all of them were part of their local community. They had existing relationships and networks within their community, and particularly now, kind of almost 8 years on from the first LEAP program, they're really now recognised in their local community as a resource person. And so they get so many referrals by word of mouth as well as through a lot of the government services. So it's been really lovely to see the evolution of those roles in their communities. Another important strategy that we've used to improve access is to use very inclusive list of risk factors for screening. So in many settings, obviously, caregivers' health literacy and lack of medical records may be a barrier for them to access some of the screening programs if they're built around specific risk factors. And so we've typically simplified them down significantly to allow that access. Some sites using universal screening, so not even looking at a risk factor, but doing it within a developmentally vulnerable population like the tea plantations, or in some of our other sites, just asking a very general prompt to the mum, was there anything that went wrong during your pregnancy or the birth? Anything that you were concerned about? And that was enough then to prompt us to do the screening. And we also we used a very broad definition of preterm and low birth weight. So we were screening anything less than 37 weeks and less than 2.5 kg. And we also did a lot of education with parents, particularly around some of the things they might notice in their baby's development. And so we did that as part of some of these community awareness activities and parent education groups. This is just a little bit of data. I won't get you bogged down in it, but this was data from our 800 babies in the first LEAP India trial. And this isn't all of the risk factors that we recorded, but they're the most frequently reported ones. And you can see in purple is the number, absolute number from the high risk of CP group, and in grey, the low risk of CP group. And so infants with a greater total number of risk factors, babies born extremely preterm with HIE or birth asphyxia or seizures within 72 hours of birth, were the ones that had significantly higher odds of having a high risk of CP outcome. And infants who were low birth weight or a NICU admission had significantly reduced odds of being high risk relative to other risk factors. So it doesn't mean that reduces their outcomes of having CP, but they were the ones that were less predictive or less associated. So as far as if you've got a service with limited manpower, I guess it's those first 4 risk factors that seem to be the ones that really we need to be prioritising for screening. And it's also just really important to think through what will be most meaningful to build trust and engagement within your screening programs. Maybe that's having a respected community member, having a trusted community agency, promoting within universal child health programs like your routine immunisation clinics, things that families are already familiar with and engaging with, things like video vignettes that can go onto phones, or in First Nations Australia, we've decided that a culturally co-designed fact sheet is something that would be meaningful for families. And so we're in the process of co-designing fact sheets. So there's a range of different ways that we can engage, but I think the really important thing is to think about the engagement piece, and really do that in conjunction with your local community. So designing along with, co-design is the buzzword at the moment, but to make sure that these resources or engagement strategies are at the right level and in the right format. The next or the second principle of LEAP screening is that building on local strengths. And so the first I just wanted to touch on is that idea of the geographical and staffing components of the site are certainly considerations that may inform that selection of the identification and screening strategy. So for example, in LEAP India, we had a distributed community-based identification model, which was largely built from the organisation's existing service delivery in the community. So they were already had community hubs, and so we could build on them. Whereas with the hospital site, it made sense to build on what they were already doing within their high-risk follow-up clinics. And they were already targeting those babies that had the risk factors. So it was a way that we were able to actually provide screening service across 10 million people, but with a relatively efficient process. And the hospital site, of course, from an organisational policy perspective, didn't already have personnel in the community. So again, it's just an illustration of really working with what the community and the agencies are already doing. Another strength we were able to build on, which I mentioned briefly, and I think it's just a really beautiful example, was within the urban slum site in Kolkata. They were already doing all these very beautiful family and parent groups around child nutrition, child health, accessing health-seeking behaviours. And so we were able to kind of build in with those programs, education around child development and child wellbeing, and in addition to that, identify any babies that might need some additional support. And health camps, I think many of you would be super familiar with health camps as again, an identification strategy, and using that kind of tiered screening approach, which means that you might start with a broader screening question first, which might be just asking about, were there any things that you were concerned about in your pregnancy or your baby's birth, or it might be asking about specific risk factors. And then as the second tier, you might have your allied health team actually conducting general movements and or HINE. The gold standard tools. So I've already spoken briefly about the general movements in the HINE. And as I say, I know it will be a topic of future webinars, so I won't talk too much to this, but it is one of the really key components of the LEAP program. We know that the International Clinical Practice Guideline by Novak and team promote the use of, well, 2 different pathways. Pathway A, using the best available evidence with neuroimaging plus general movements, or pathway B, when MRI is not available, often in the case of some, or in some LMICs, using the general movements plus the Hammersmith. So training came up on that list of barriers, and I absolutely agree this is probably one of the big barriers, particularly for something like the general movements assessment, that we need to be thinking collectively about how we overcome, because I think once you've got that training, then the actual use of the general movements is quite effective in that low income context. We've been really fortunate within the LEAP programs to coordinate general movements trust certification training, both beginner and advanced, at all of our sites, so in India, Sri Lanka and Georgia. And the General Movements Trust have increasingly been conducting courses in low middle income countries. So there's over 40 countries that have been accessing training to date. Of course, the benefit of the HINE is that you don't need to be formally accredited to use the tool. But that being said, we would recommend, when possible, accessing formalised training courses, as it really does improve the reliability of both the administration and the ratings. And there are also options to access training videos online, and I think that link there is one of the key access points for that. In addition to the formal training on the screening tools, it's important to consider training for your frontline staff, so the ones who are doing the identification, as they're often the ones collecting the general movements videos, and also often the ones identifying babies who might benefit from the screening in the first place. So in all of our sites, we've conducted a lot of training for the teams to understand which babies should be screened, so the risk factors of CP, how to collect a general movements video, including developing simple picture-based prompt sheets like the one on the slide, and how to adjust the baby's age for prematurity, which is obviously important for getting the timing right with the GMA. Another important part to making sure both general movements and HINE are providing accurate information is ongoing or multiple raters, as well as ongoing calibration. So we generally have at least 2 independent ratings of the general movements, and then it goes to a third consensus rater if there's disagreement. And we also, for all of our sites, have regular calibration meetings for those doing the ratings, where they review complex cases as a group. And Carly Luke is publishing some great data on that at the moment, speaking to the importance of calibration in keeping accurate with your scoring. The timing and combination of tools for predicting CP is, again, one of those balancing acts that we all need to perform between the accuracy of the tools when you can use them in combination, but also the feasibility. To have to follow up families at multiple different time points can be quite tricky in your contexts. So we know that if you use the general movements plus HINE plus neuroimaging, you can get up to 99% accuracy, which is brilliant. But we often need to make strategic decisions as far as what's going to be most feasible in our context. So in LEAP India, we use just a single general movements assessment at fidgety age, or a HINE assessment if they were older, and that indicated eligibility into the program. But we have, since doing that, decided that as much as possible, we're recommending the 2 general movements assessments, because we just really think that that does enhance the accuracy quite significantly. We also, in Sri Lanka, have been using the HINE a bit more because we're not always getting the babies at that early age point. So confirming an earlier HINE at the 6-month point to improve accuracy as well. And just to flag, again, I think it will come up at future webinars, but there are different cut points published for the HINE with different levels of accuracy, depending on which cut points you use. And also they pick up kids who are more likely to be CP versus kids who are more likely to be neurodevelopmental, adverse neurodevelopmental outcomes. So being considerate about which cut points you use can also make a difference. I won't go into this in detail, but just again to flag that this data will be hopefully published soon. This is from the sample in India, and we looked at how predictive the general movements or HINE were for later diagnosis at 1.5 years of age. And we were able to get quite strong sensitivity with just that single assessment point, but the specificity was much lower. And so that's where we've been reviewing what would be recommended with the type and timing of tools. Finally, the LEAP program, we prioritise processes and systems that can lead to scalability and sustainability. And this really informs our decisions around the setup of the program. So I've already touched on kind of thinking strategically about the different elements within, from identification to collecting a general movements video, to administering the hind, to scoring, to communicating results, and thinking through who might be most suitable to do each of those elements, because it won't necessarily be that your team does it from the start to the finish. And I think by thinking about it in that way, we can really embed more effectively within local health services that might be doing certain elements of that work really well already. So one beautiful example is the work that the Leap India team has done since the conclusion of the RCT. So they've scaled up to 6 geographical blocks, which is a population of over 1 million people. And they've done some really incredible work building partnerships with the antenatal workers. So they're called ASHA workers in their communities. And they've trained over 1,300 of these women who are already in the homes and already got trust and relationship with the mums around the antenatal and initial postnatal care of babies. And these women are now the ones who are identifying the birth risk factors and referring through to the LEAP program. And that strategy, as well as I think just really increasing the sustainability of the program, has really increased the reach and penetration. So we've had over 1,200 referrals from those ASHA workers already. And I've already also mentioned, but I just wanted to highlight it because I think it's a really great example of sustainability with the Sri Lankan team doing this universal general movement screening, because they recognised that the tea plantations were already a context with more developmental vulnerability. They made the decision that, and in addition to that, also a context with lower health literacy and less medical records. And so they made the decision to actually roll out universal screening with the general movements in this context in partnership with the Child Development Services. So these are the teams already providing the early childhood nutrition monitoring, nutrition and growth monitoring, routine immunisation clinics. And so they've just embedded the general movements into their existing programs. And I think it's a great example of how we can really build for sustainability. And the Georgian LEAP team also looked at, I guess, the idea that they currently have a lot of the services are in the capital in Tbilisi, but wanting to really increase access and reach across the country. And so they've addressed that by training up, doing regional doctor training sessions around things like awareness of cerebral palsy, risk factors for CP, early signs, gold standard tools, and about early intervention, as well as doing some hind training for them. And so they've trained up over 100 doctors to be able to create better screening uptake. So I think I've talked enough. You're probably starting to go a bit cross-eyed. But just to summarise some of those key things, I think the challenges you guys would be well aware of, but some of the ones specific to the LEAP program are around the awareness of early detection and intervention in your contexts. And that's not just with families, it's also with your medical professionals. So doctors who are still saying, oh, just wait and see, it's nothing to be worried about yet. But so we've done a lot of work creating awareness in both of those groups. Families still sometimes feeling like at 3 months when the general movements is offered, the disability is not as evident. And so that's been a barrier for them agreeing to do the general movements. Access to training and calibration we've spoken about, but I think that's a really, I imagine that Israt and the team are already scheming about ways that we might be able to really create communities of practice and build on the networks around the region, because I think there's so much knowledge and wisdom already in your communities, but sometimes it's about making those linkages and connections, which is the next point around collaboration and partnership. I think certainly in India, it was a really big barrier, birthing hospitals not necessarily wanting to refer to the community service providers, and then community service providers not necessarily having access to physicians as far as that overall management of CP or early developmental concerns. And so I think just really that was something we spent a lot of time building, intersectoral kind of collaborations to really enhance the care pathway for those babies. Loss to follow-up was a massive issue between migration to different areas and losing contact, moving from different services, or just changing their mobile phone numbers and losing contact that way. But particularly for needing to follow up children, if you are doing multiple screening appointments, that contact is a definite challenge. And then finally, accuracy of the screening assessments. So if you're only doing a single general movements video, it's obviously more feasible, but you're not necessarily getting the accuracy. And similarly, we opted to score all of our hind videos, score all of our hinds from video so that we had consistency in the scoring, as well as it meant that we could more easily upskill clinicians to administer the items. But then, of course, it's got its limitations being scored from video. Access to appropriate smartphones for recording and internet for upload, particularly if you're looking at multiple raters for the same videos. Families not always knowing the gestational age of their baby and or the risk factors, which we've spoken about already in the presentation, and getting the timing and follow-up right. So if I could distill it down to some key take-home messages, if you were wanting to start using general movements and hind in your communities, this would be some key recommendations. Aim to deliver in your local communities as much as possible, because I think it just really enhances families' access to these programs. But of course, like I've already discussed, we do need to be strategic with regards to organisational and workforce constraints, funding, and different priorities of the organisation. And so I think, like anything, we need to weigh up the pros and cons of our choices. Building on the community and organisational strengths, and analysing barriers that there may be, so that you're really designing strategies and programs that meet the needs of that specific community. So certainly not a one-size-fits-all. Partnering with existing service providers who have established networks and trust in the community. It was something that came up time and time again in our interviews with families about what made the LEAP program, screening program, helpful. And it was, we knew that organisation, we trusted that person, we already knew them from the community. So I think trust is absolutely key. And so thinking about, even if your organisation isn't the right person for that initial engagement and trust, who are the right people? Really trying to embed as much as you can, even if it's just certain parts of that process within existing services to really enhance sustainability. The general movements and hind, both really great tools, but of course we need to just think about the complexity around accuracy versus feasibility and who our target recipients are. And offering screening as much as possible in conjunction with interventions so that it's meaningful for the families and it serves the purpose of why we screen in the first place. So thank you so much, and I hope I haven't bamboozled you too much. And I believe that once we've got Raj and Gulam and Anna, if they've been able to jump on, they'll be able to also give you lots of great information from the ground as well. So again, just acknowledging all of the different partners that have been involved with this work. I feel very humbled to be sharing about the program on behalf of everybody, because it's everyone around the world who are doing the work. And I'm really happy if you want to reach out with any specific questions after today. My email address is up there on the slide, so, and I can forward it on to anyone who needs to answer the question.
Thank you so much, Kath. Just one comment from the audience, I think. Could you please share your last screen with the email address again so that they could
Sorry,
note
yes.
it down? No, it's all good. Wow.
Oh,
Great
sorry. Oh, and I
presentation.
didn't click on. Sorry, that's why. My
No, it's
apologies. I
okay.
was clicking on my wrong screen. I've got two screens up and I didn't show that either. There you go. Sorry, guys. I managed the two screens well up until now.
No, perfect. It's all good. No worries. Thank you, Kate. Thank you so much. It was really, really a great presentation. And I really love those slides about the scalability and the collaboration and like, yeah, and the Asha slides. Wow, very inspiring. And thank you for sharing your experience and this, yeah, amazing program. Any comments for Kate? Is it okay? There's one comment. Is it possible to you could unmute yourself and just ask the question directly. But like I'm reading out from chat box. One question from Dominic is it possible to share some links to tools like GMA Hein and some documentation like flyers for parents? So, Kat, do you have like, is there any link where we could access the communication or resource materials that's been used for LeapCP?
I'm very happy to make them available. Maybe we can
Yeah,
chat
sure.
about it. It's right. Yeah, at the moment, Leap doesn't have like one website, but we do have a lot of different materials that have been developed by different teams.
Perfect.
And yeah, I'm always very happy to share. So, and for people to then further adapt as needed. So yeah, maybe we can
No.
either take that person's email address or yeah, discuss a strategy for that.
No, that's really thank you so much. We could make those like we can send this email directly via email, or we could use JLMCPR website as needed. So we will discuss about it
Yeah.
further and let's
And if
come up
people
with
do have a specific
solution.
thing that they wanted sent, just email me as well. That's also
Yes,
fine.
please. Here is Kat's email address, and please contact her for any further communication. Any other specific question regarding LeapCP?
Hello.
Yes,
Yes,
Hilary.
please. Hello. Yes, thank you very much for the wonderful presentation. I would like to ask, based on your experience and practice, we here in our practice sometimes we have challenges of false positive and negative in terms of diagnostic of children with CP. So kindly, what measures do you suggest to minimize false positive and negative during community-based screening? Thank you.
Yeah, I mean, it's a really good question, Hilary, and I guess that's what I was trying to allude to on that slide of we are constantly in a push and pull between accuracy, so minimizing our false positives, false negatives, and feasibility, so not having to chase up families for 2 GMAs, maybe multiple Hines. So absolutely there are ways to minimize it. You saw that there's 99% accuracy if you've got GMA plus Hein plus neuroimaging. We can be quite certain that that's accurate. But in our contexts, I think we have to be pragmatic. That's my honest belief. And I think it's about asking your organization or your team the hard question of how many false positives and how many false negatives is okay, and then making decisions about how many follow-up assessments you choose to do based on that. Because and for that reason, our team opted to communicate more around your baby is at an increased risk for needing extra movement or learning support, rather than saying your child has cerebral palsy, because there were some, as you saw, some false positives, false negatives, and always checking in again with families to say, if anything changes and you have a concern, definitely still come and see us. So I guess they would be my pragmatic solutions, is not necessarily trying to eliminate them, but always trying to make sure that we are still getting the right babies supported.
Thank you.
Yeah, it's actually it is very difficult to get that fine balance, like where would we stop, like how to, yeah. Any other question? I would not pick on the audience. Aaron, like I know that you have you study early detection of CP in Malawi. Would you like to share any experience that you have, maybe with the team? Or Abir, Masad, you also have, I'm familiar that you also run a similar program like for early detection of childhood onset disabilities, not particularly CP, but yeah, if you would like to share a few words and
No, in fact, I'm Abir Masad from Lebanon. In fact, we are far from implementing this program, but we just started with the first step with a survey distributed to all healthcares who might work with children under 3 years of old. And now we are going to collect data just to prove that we are far from this practice and that we need more trainings to implement this process either in hospital settings or to implement like community-based. But I think we already started with the first step just to have some numbers and to show to the concern that we need some trainings and we need to implement appropriate processes so we can move forward to the next step to implement some early detection programs. But I hope we will reach this point soon. So we will be in touch, I think. Once we have the survey results, I think we can discuss more how to implement such program. Thank you. Very nice presentation. Very interesting.
Thanks,
thank you,
Abir.
Abir. Thanks. Well, to be, I don't know if you're aware of the program that we did in Bangladesh. Like Mahmoud will be talking about a lot more about community-based model we are trying to implement in Bangladesh, but we also did an institutional-based identification. Like we tried to use GMA, HINE, and other tools. So there was an early detection of CP and among children with cerebral palsy in Mymensingh, Bangladesh, and we recruited participants from NICU, and the project was funded by CPA. And if you're familiar with Dr. Tasnim Karim, Dr. Anna, and Dr. Kathy Morgan, sorry about that. So they implemented that project, and like it was really amazing, and the sensitivity and specificity was quite high, and we identified like children we diagnosed children with CP at 6 months of age, which was like amazing finding. But the major challenge we faced, I think, because it was an institutional-based recruitment, we could not follow up with a lot of kids who were diagnosed to have CP, but like, ensuring that they are also receiving early intervention, that was quite challenging for us in Bangladesh. So I'm not gonna delay anymore, or I'm not trying to speak of Mahmoud's content or steal Mahmoud's content, but like he will be talking more about the community-based component that we are trying in Bangladesh as part of CSF's ongoing projects. Kat, any other words that you would like to share? No? Okay.
But just, yeah, thank you again. And I look forward to learning more together as these webinars unfold. Yeah, thank you so much.
You.
And
Thank you
I
so
need to
much.
jump off, but Raj is still here if people have questions about LEAP at the end.
Okay, so if you're planning to, okay, can we have a group photo if that's okay? Because Kat may leave in between till our session ends.
Yes,
Yeah, okay.
that's it. Okay.
All right, let's have a photo. If it's okay with you all, could you please turn on your video camera? Sorry. Okay. Ready, 1, 2.
Oh, cameras might still be coming on, Isra.
No, okay. Sorry, I will wait for a few more minutes. Sorry, I'm really bad at this.
They're slowly flicking on. And you've got 2 pages. You might want to do 2.
Yes. More cameras coming. Okay. All right, let's start. I will take a few snaps. Yeah, I think we have got everyone. Thank you so much. Um, Thank you, Kat, for joining us today and for your wonderful presentation. We have Raj. If you have any question, guys, like please feel free to text on chat box and reach out to Kat to her email address, and we will also upload this presentation later once it's like once the webinar is completed, we will upload the record for our audience who have not been able to join this meeting today. Thank you. All right, moving on to our next speaker. So we have Dr. Mahmoudul Hassan Alimam from CSF Global, Bangladesh, who will be talking a little bit more about the community-based model for early identification and intervention for children with CP in rural Bangladesh. Thank you, Mahmoud, for joining, and I'm handing it over to you.
Thank you, Shrat. Let me share my screen. I hope you are seeing my screen.
Yes, we are seeing
Yes,
it.
we can.
Thank you.
Thank you. Welcome everyone to the webinar again. My name is Mahmoudul Alimam. I am a postdoc at Sikh University and senior research physiotherapist at CSF Global. Now I'll be presenting an innovative community-based early detection and early intervention program for children at risk of CP in rural Bangladesh. Before we begin, we need to understand why a community-based early detection and early intervention model is essential, particularly in low-income settings. Let's review the current status of CP diagnosis and intervention. In Bangladesh, most of the children are delivered at home, and over 2/3 of the deliveries are attended by traditional birth attendant. Additionally, the age of CP diagnosis is significantly delayed, which is 5.2 years in Bangladesh and 1 to 2 years in high-income countries. Access to early intervention is very limited. Only 8% of the children recruited to the Bangladesh CP register receive services before their first birthday. And also there is high prevalence of risk factor for CP. For instance, 20% of the babies have a history of preterm birth or low birth weight or birth asphyxia. So that conventional hospital-based CP screening program is not pragmatic in this setting. So what could be done to change the scenario? Ideally, we need to ensure that all births are attended by health professionals in institutional settings. The Bangladesh government has taken many initiatives to facilitate institutional deliveries and to train skilled birth attendant. However, we are still lagging behind because of many reasons, including lack of manpower, resources, facilities, and also most importantly, the use of a top to bottom approach. So what can you do as a service provider or research organization? We can offer early screening and diagnostic services. We can establish early intervention and rehabilitation program. We need to take a bottom-up approach to design a community-based service delivery model. After consulting with parents of children with CP and community health worker and birthing service provider, we have co-designed the community-based CP early detection and early intervention model. The model includes engagement of consumer and community to create awareness about the risk factor for CP and enable referrals, training of birth attendant, community health worker, and developing a referral network to identify infant at high risk for CP early, developing a community-based screening program using existing rehabilitation center for early detection and early intervention, and conducting research to provide a comprehensive roadmap for early detection and early intervention. Let me explain some key terminologies that I'll be using frequently during this session. Empower or Mother's Power Group consists of 10 to 12 mothers of children with CP. These groups aim to empower mothers or caregiver with knowledge on day-to-day management of a child with CP and provide a safe space to enable discussion around their concerns and issues in daily life. So far, we have formed 45 Empower groups. Key informant networks are a network of community volunteers who are trained as key informant to identify children with CP following the key informant method. Just for your information, our second webinar was on the key informant method, and the full session is available on the GLM CPR YouTube channel. So far, we have trained 636 key informant in this study site. Smart CP centers are part of the Smart CP model, which stands for Sustainable Model of Early Intervention and Tele-Rehabilitation for Children with CP. The Smart CP model includes a village-level referral network, sub-district level rehabilitation center known as Smart CP Center, and a centralized tele-rehabilitation team to support the services of the Smart CP Center. We have established 4 Smart CP centers in 4 rural sub-districts of northern Bangladesh. Our early detection and early intervention program aims to empower consumers, raise awareness in the community about the risk factor of CP, improve technical knowledge of birth attendant and community health worker, and facilitate early detection and intervention closer to the home. There are 6 key steps in the early detection and early intervention program. Social mapping of birth attendant, community health worker, and newborn care provider, training on newborn and infant detectable risk factors for CP, mobilization of existing referral sources, including key informant network and empower groups, follow-up and collection of list of high-risk infant, screening for CP, and early intervention. As part of our social mapping initiative, we have identified key stakeholders involved in the birthing and newborn care services. This comprehensive list includes doctors, nurses, midwives, birth attendant, vaccine provider, and community health workers. We have identified 768 potential stakeholders so far. We then organized half-day training sessions for the potential stakeholder using a manual titled Detecting Cerebral Palsy Early. The session covers definition, symptoms, risk factors, early detection algorithm for CP, and the role of community health workers in CP early detection in plain language with case studies. And at the end of the training session, handouts including risk factor of CP and referral forms are shared for future use. As part of the community mobilization, birth facilities, hospitals, newborn clinics are sensitized to join the referral network. Additionally, empower groups, key informant networks are trained and mobilized to identify, refer infant with high risk for CP. Furthermore, posters or flyers depicting risk factor of CP are distributed to raise awareness and to support the early identification effort. To date, we have trained 398 potential stakeholders, including doctors, nurses, vaccine provider, community health workers, and birth attendants. Following the training session, we conduct weekly phone follow-up with the referral networks to collect the list of high-risk infant. During this phone follow-up session, we remind the trainees about the key risk factors to ensure that they remembered what to look for while providing newborn care or birthing services. Infants identified by the referral networks are then invited to attend the early detection and early intervention clinic of the Smart CP Center. For screening, we use highly sensitive and validated tools such as general movement assessment, Hammersmith infant neurological examination, and developmental assessment of young children. Home visits are conducted for screening in case of difficulties reported by the parents. Here we can see the algorithm for early detection of CP, including newborn detectable risk factors and infant detectable risk factors. However, we have adapted this algorithm in consultation with early detection experts, considering available resources and tools. For screening, we use GMA at 3 months, HINE at 3 months, 6 months, and 12 months, DAISY at 6 months and 12 months. Children identified as high risk for CP following screening undergo further assessment using Peabody Developmental Motor Scales, PDMS-2, at 3 months and 12 months, and gross motor function measures 66 at 6 months and 12 months. To confirm the diagnosis of CP, a pediatrician clinically assesses the high-risk children. An adapted version of the Australian CP register CP description form is completed as part of the diagnostic process. Infants identified as high risk for CP and confirmed CP are offered free early intervention services at the Smart CP Center fortnightly. In the last 11 months, stakeholders referred 276 potentially high-risk children. Among them, 232 had newborn and infant detectable risk factors, achieving an 84% accuracy. Out of the 137 children screened, 60 infants were categorized as high risk for CP, and 29 infants received a confirmed CP diagnosis. The mean age at CP diagnosis was 6.2 months. All infants diagnosed as high risk or confirmed CP have received early intervention services. Our model is effective in identifying high-risk infant and detecting CP early, but there are challenges. The stakeholder engagement has dropped over time. For this, we have organized refresher sessions and plan to offer financial rewards for high-risk referrals. Parental awareness about early detection services is low. Therefore, we provide evidence-based education to raise awareness. Parents often do not realize their children need screening due to the lack of visible impairment. We educate them on developmental milestone to help recognize missed milestone. We are also introducing transport allowances to encourage screening. Some parents do not want to bring their children to the center because they fear that others might learn about their disabled children. For this, home-based screening and education on early intervention benefits have been found to be effective. Our preliminary findings indicate that the model is effective. We have found that the community-based screening program for early detection and early intervention of children at risk of CP in rural Bangladesh is both feasible and successful. This model shows promise for scalability in the similar economic settings. If you want to develop a similar community-based early detection and early intervention model, please feel free to reach out to the GLM CPR team for technical know-hows and resources. Please feel free to share if you have any question or comments. Thanks for listening.
Thank you, Mahmoud. Thank you very much for your nice presentation. Any question to Mahmoud? I know that this program, like as you have explained, I know that this program has we just started and we have a long way to go. But looking at the community-based content and the challenges that you have explained, I'm just wondering if this is similar or any different experience that LeapCP program has faced, maybe in the beginning when they started, because we are from this almost similar region, especially in India. So if any, Raj, would you like to comment on the activities or experience? Is Raj here? Yes. Yeah.
Sure.
Raj.
Can you hear me?
Nice to meet you. Thank you for joining. So I was just wondering because Mahmoud was talking a lot about because the program is community-based component is just starting, and the challenges that he has explained is I think would be almost similar in India. So would you like to share your experience?
Yeah, in Sri Lanka, also we face the same problems. Hello, can you hear me?
Yes, yes.
Because I'm on.
Yes.
Yeah.
Yes.
We also face the same problem, especially the awareness is a big problem in our setting because the early intervention and early detection was very, the people having less knowledge about that. So we struggle to give more awareness about that. And finding the tools and resources are the same problem. Yes, exactly. In our setting, the same problem which we face at the beginning. But with the time, we were able to overcome with the collaborations and from the support from Queensland University. So with the time, I think we can overcome. Yeah.
Yeah. True, agreed. Any strategies you followed, like in addition to the educational program and the resources that get shared, and your extensive reach and community access in terms of ensuring equity? Any additional suggestions that you may have for Mahmoudul and the program?
Thanks, Ishrat, for asking this question. I was about to ask about it.
Yeah,
Please,
sorry,
Raj,
Mahmoud,
please
I'm not.
feel free to
Yeah,
share your
please.
experience, how you dealt with the challenges, and how what are your strategies, and what worked and what not.
Okay. Mahmoud and Raj, for both of you, I guess there is a question from Aaron. In poor resource settings like Malawi, would it be appropriate to modify the HINE to identify these at-risk children? Feel free to add your comment. Mahmoudul?
Oh, sorry, what was the question?
The question was in rural settings like Malawi. So would it be convenient, like if would it be okay if they want to?
Hi.
Yes,
I
Raj.
didn't
Yes,
get the
please.
question.
You did, okay, I will read out the question again.
Okay.
Just give me a minute, please. I'm looking at one single screen and it's making a bit mess for me. Yes, the question is from Aaron. In poor resource settings like Malawi, would it be appropriate to modify the HINE to identify these at-risk children? So he's asking, Aaron, please feel free to unmute yourself and ask the question. But if I understood correctly, if you wanted to learn, like ask if modifying HINE in terms of like
in terms of
how
what,
frequently?
Like,
Yes.
Yeah, if you want to, for example, the in some studies they recommended the use of HINE at 3 months, 6 months, 9 months, and 12. But however, we have adapted considering our resources and experts. We have adapted it as like to 3 months, 6 months, and 12 months. We have excluded the 9 month screening. So that sort of change can be made. However, you cannot just change the tool, like you cannot exclude some of the question. So yeah, that's the advice I would give.
Thanks, Mahmoud.
So,
Raj, anything to add?
yeah, so in my point of view, as Mohammed said, like we can't change the tool because it was standardized and validated. But you can, what Leap did in India was, so we trained even the local people who are non-health workers as well to do the HINE, because finding a resource person is very challenging. So that's why we trained the local community persons to do the HINE as well. And also, if we are find it difficult to do frequent HINE, I think 6-month HINE will you give a better result.
Yeah, that's actually a very great idea. Did you like what's the like I'm sure you have this documented and you publish this data, but what's the inter-rater reliability of like a trained assessor or a professional doing the assessments, and when you are teaching community workers to assess high?
It was quite good, but the thing was we were doing continuous like calibrations with them.
Yeah.
So continuous calibration makes a little bit more perfectness. So still they need to be trained a little bit more, because like finding the tone and stuff. But most of the time it was very good.
This is, yeah. No, that's actually how, that's really amazing. Mahmoud, this is one thing we could adapt maybe.
Yeah, currently we are using qualified physiotherapists to conduct high assessment, but that's a good suggestion, like use of local community member and try to use them to conduct high assessment. Yeah, that could be a good suggestion for Malawi as well. So
yes,
yeah, if I don't think that there is a less qualified professional, they can think about training community people on high so that they can perform the high assessment.
But I think across like for all settings, it's going to be very important to ensure calibration, like, and as Raj was mentioning, that we need to do continuous assessment checks if how consistent are the ratings are for a professional and semi-professional. Yeah,
absolutely.
There is another,
because conducting assessment is one thing, and getting the accurate scoring and making the cutoff of like whether the child has high risk category or not, it's a very important thing. So if we cannot like make sure that we are getting an adequate scoring from the community people, it would be like difficult to interpret and diagnose the children.
Yes. There is another question from Abir. How long do you provide intervention for children with CP, children with a confirmed CP diagnosis? I mean, after early detection. So once diagnosed, how long do you provide the early interventions for?
For the Bangladesh study, we Bangladesh study, we have planned to provide early intervention services fortnightly for at least 12 months.
12 months, okay. Raj?
Actually, the study was, we are providing intervention for 12 months, but we follow for 2 years. But it was intensity. So we usually, every week we visited the family and provide support. So the intensity was high. The study we did for 12 months.
So I think, and I think it also depends on the resources and the mode of intervention you are planning for, especially if it's home-based. Yes, please.
Yeah, and the financial backgrounds, and there are other factors will come and play.
Yes. But Abhi, to answer your question, both team is now delivering 12 months intervention, however, following for a longer period of time.
Yes, thank you.
Thanks. There is another question from Mbapa. How did the team manage to ensure free early screening and intervention for children and high risk for CP, given that financial constraint is a major hindrance to appropriate health-seeking behavior in LMICs? Very important question.
Yeah, that's a very good question, Mbapa. Thank you for asking this. Initially, we started the project using the internal funding of CSF Global. However, we got an emerging researcher grant from Cerebral Palsy Alliance Australia to conduct this study. So it's a funded study right now.
Yes. Raj, how about you?
Yeah, but in our Sri Lankan context, usually, so our health service was free of charge. So when we are doing our hospital-based screening, it was free. And also, there's a grant from LEAP CP, so it was helping for us. But in the plantation, the factories of tea, they support us. So that's how it was able to make it as a free service.
Yeah, it's very important. So initially, I guess for all of our projects in low and middle income countries, it's mostly funded, of course.
Yeah.
But then gradually, for sustainability, as you both have emphasized, it's better to have collaboration and internal funding, and later, try to embed the activities in existing healthcare program. I mean, that's the best shot you can have. So, but for that, anyway, that experience may vary from country to country, but yeah, that's what Bangladesh and India have done. Any more questions? I think the team is now planning to how to write proposals and all this stuff. I'm hoping. Anyway, any other words, Mahmood and Raj, from your end?
From my side, no. I'm happy that I got a great opportunity to meet you all guys, and thank you very much. Yeah.
Well, thank you very much for joining and for the great work that you have been doing. The team is doing.
Yeah, I'm looking forward. Yeah, that's a good thing of sharing knowledge with each other and learning from each other, and because all the experience are valued there.
Yes.
Absolutely.
Yes.
It was nice meeting, Raj. So we'll be connecting later.
Sure, definitely. Thank you.
Thank you. Mahmood and Raj, if you don't mind, could you please share your email address on chat box if anyone wants to reach out?
Sure, definitely.
And you all have Kat's email address, so if you want to contact her in this regard, please feel free to reach out. And in the meantime, I will share my screen again and I will ask questions again. Sorry about that. Oh, sorry. Mahmood, would you please stop sharing so I can share screen for
Sorry. Yeah.
Oh, it's all good. Yes, thank you. Let me share my screen again.
Yeah.
Okay, we will give another try. Can you see my screen? I hope you can see my screen. There's another, so we would like to know about your feedback on these models. Could you, if it's okay with you, could you please log into menti.com, use this code, or scan this QR code just to let us know what you feel about feasibility of these two models that Kath, Raj, and team and Mahmoodul has explained or discussed. Awesome, already one. Yes. Looking great for you. Thank you. It's very very positive. So everyone thinks that these models are very feasible, which is really, really good. Out of curiosity, those who already have their community-based program that you have mentioned in earlier query, what do you think? Is it do you think there is anything new to add, or was this session helpful for you? Any comment would be very much appreciated. No? All right. mind to could you please share your experience or comments why you feel like maybe what could be the potential challenges? Because I understand that there would be many challenges for starting an early detection program in LMIC settings. You're very quiet audience. Okay, moving to the next slide. Any other comments? No comments? That's okay. I will give it another few seconds. All right.
I think Ishrat, maybe we'll
I
take some
think
time
everyone
to...
has, yes. All right, I will stop sharing my screen. Please feel free to leave your comments because those surveys are still on, and I will share the findings later when we share link of the video. Thank you so much for our thank you very much to our speakers and our participants for your active participation. I think it has been a really, really good session because we are now at a stage where we are looking into evidence. We are trying to get evidence about childhood disability, cerebral palsy in LMICs, and early detection is a very, very common challenge for all of us. So it was really nice to learn about these two models, and I'm really glad that you all stayed till the end of this session. If any of you have anything to say, feel free to reach out to GLM CPR, and please share your feedback about our webinars. And there will be 3 more webinars this year. The next webinar is scheduled in August. So please check our GLM CPR website and register for the upcoming sessions. A big thanks to Dr. Kat Benfar, Dr. Mahmoudul Hassan Alimam, and team for joining this session and for sharing their experiences. And many, many thanks to all of you. We look forward to having you. Yes, please, Mahmoud.
I just wanted to share the news of our next webinar. So our next webinar is on early detection and early intervention of children with CP. So it will be facilitated by Assistant Professor Kathy Morgan from Cerebral Palsy Alliance. So those who are interested to know more about different tools and techniques and how to use those tools, please feel free to join the next webinar in August.
Yes.
Thank you.
Thank you. Thank you, Mahmoud. Okay, I think we can close this session today. Thank you so much for joining, and have a wonderful weekend or weekdays and rest of the day. Enjoy, and bye.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Thank you. Have a nice day.